guys, so tonight or today, wherever you're at or whatever time it may be for you, this is the second half of the diabetes PowerPoint. And so this is another long lecture. So if you're looking for more short, sweet, simple to the point videos, you should check under my Unit 1 playlist to see more short, sweet, simple videos. If you're looking for a longer lecture, more in-depth about diabetes, you're to the right place, I'll put it that way. So this lecture is going to cover chronic complications of diabetes as well as diabetes medications. So there's a lot of information here. Medications are always hard to lecture over, and I'll talk about some suggestions I have for you as you're studying through this material to move forward and really start to understand this. So in my last lecture about diabetes, we talked about how diabetes affects blood vessels. It breaks down and irritates them. And so we're going to kind of talk about what happens then more long-term as the damage from all the excess glucose builds up. And this really brings back to the whole point of why we're focused on euglycemia or managing that blood glucose, because all the sugar in the blood just causes so many problems. And one last note is just that also with patients that have type 2, sometimes this is how they can present. When I was talking in the beginning of my last lecture about how people with type 2 diabetes sometimes present with complications first, this is what I'm talking about, is that sometimes they can go to their eye doctor and find out they have diabetic retinopathy before they even know they have diabetes. So just know all the damage from the sugar in the blood can be happening way before the patient even knows they have diabetes. So first, talking about eye problems. Know that, and you're going to see this is kind of a common theme for all the complication, that diabetes is the most common cause of some major problem, and it is the most common cause of adult blindness. What happens in diabetes, like I brought up, is all the sugar irritates blood vessels and those tiny blood vessels in the eyes, and it leads to these little hemorrhages or bleeding forming, which decrease vision. It's usually a result of too much pressure. Like usually these patients also hand in hand have high blood pressure issues, but also irritation of the blood vessel from all the sugar. Other eye problems that are common are going to be glaucoma and cataracts. They're going to have a higher incidence in patients that have diabetes. And pretty much in order to manage this, of course, preventatively getting regular eye exams, like we talked about before, is so key. But we also want to do things to manage the problem. So if the problem is too much sugar, I need to manage that. I need to keep their blood sugar stable and under control. Watching their hemoglobin A1C regularly and seeing kind of how they're keeping that under control, if they're taking their medications, are their medications working for them? If they're not on medications, how's their lifestyle stuff going? That's key. So kind of keeping an eye on their blood sugars, and then also treating their high blood pressure if that is an issue for them. So they may need antihypertensives. You don't have to know the names of the antihypertensives, but just know that it's possible that they may be on them. There are surgical procedures to help to improve diabetic retinopathy, which, and by the way, in case you didn't see it, this is how you spell diabetic retinopathy. There are surgical procedures that can be done. You don't have to know about those in depth, but just know there are surgical procedures. And they even sometimes do steroid implants to decrease some inflammation that's going around those blood vessels. So then there's also diabetic nephropathy, and I have the nephro underlined because a lot of times students can get diabetic nephropathy and diabetic neuropathy confused. I even remember there was one time I was making a practice quiz for something for class, and I was looking at this practice question. I'm like, I just don't get why it's saying this one answer is right, and I looked it over and over, and I'm like, this is so wrong. And then I realized that I thought it said neuropathy and it said nephropathy. It's like your brain automatically completes what it knows best. So just be really careful when you're reading those test questions to make sure that you're reading correctly what it is. So with diabetic nephropathy, keep in mind that the kidneys, I talked about in my last long lecture about diabetes, that the kidneys are a very vascular area. And so when I have a very vascular area and I have diabetes, I'm going to be really concerned about breakdown of this area. And so there's the breakdown of blood vessels in the kidneys leads to decreased function of the kidneys, and the kidneys are kind of a big deal. They help to filter out all the waste from your body. They help to manage your fluid balance. I think there's about 400 things the kidneys can do for you probably, but those are just a couple honorable mentions there. Here we are yet again. Diabetes is the leading cause of end-stage renal disease in the United States. So I'm just really showing how serious this is. So with diabetic nephropathy, the patient's going to need yearly kidney function tests and screening for protein in their urine. If you remember back when we talked about yearly screenings, we talked about albuminuria, which is, what do you call it? You can see that there's that word right there, or albumin in the urine. We're going to regularly screen for that because that's again a sign. Because remember, normally we do not let go of protein in our urine. So if I'm letting go of protein, it's a sign that my kidneys aren't working how they're supposed to. The kidneys kind of think of it like a fishnet. Where they're letting some stuff out and keeping some stuff in. And normally when it's functioning well, those holes are not big enough for protein to slip through. But when they're not functioning well, then those protein can easily slip through. So overall, the treatment here is going to be to, again, and you're going to kind of see this is a pattern that you're going to see, is that we're going to try to maintain their blood glucose and then also manage their hypertension. So a lot of times with hypertension, you may think, hey, high blood pressure is better flow, but we'll learn about this when we talk about cardiac. It's coming. Effectively with hypertension, higher blood pressure doesn't necessarily mean better flow. Sometimes it can actually mean I'm very constricted, very narrow, and so I'm having less flow. And then this ACE inhibitors, there's something that you'll learn about next section, so you don't have to know these too in depth. This is an antihypertensive. I know on the last slide I said you don't need to know the names, but if there's any, as I was saying it, I was like, oh, on the next slide it's going to talk about ACE inhibitors, but it's all good. But ACE inhibitors, just know that these are a antihypertensive, and we're going to learn about when we talk about cardiac that it's kind of a funny thing. ACE inhibitors generally are harder on the kidneys because of the way they work. They can increase potassium and they work in the kidneys, how they, help with blood pressure and stuff like that by blocking RAS. And so because of that, they can cause damage to the kidneys. But for diabetics, it's different. For diabetics, they are actually nephroprotective, or they help to protect the kidneys. It's a more complex thing of how they do it. You don't have to know in depth how they do it, but just know in general that if a patient does not have kidney damage, we love ACE inhibitors for diabetics because it helps to kind of protect their kidney and allow them to maybe hopefully protect them from some of this diabetic nephropathy. So how about problems with feeling and sensation? Now, this is the sensory diabetic neuropathy, and there's a lot of nerve issues. So we talked about a couple of blood vessel issues. There's also nerve issues because you can kind of see here that the nerves get all messed up when there's issues with flow and stuff like that. So it's showing here that the nerves shrivel when the blood vessels disappear as the blood vessels are damaged, because the nerves are not going to get the flow that they need if the blood vessels are broken down. So the big problem is that they cannot feel, so we have to watch out for wounds. This is the most common complication. Like anytime, you should ask every patient if they have any numbness and tingling, for sensation wise, but especially with diabetics, you always want to know if they're at where they're at when it comes to sensation. Some may have a loss of sensation or decreased sensation. That's going to probably be what's most common. Most people will say, yeah, I'm numb in this foot, or I have numbness and tingling in this foot. But some people have the opposite end of the spectrum, which is what's called hyperstesia. And this is where they're extremely sensitive. These patients, you can't even put a blanket on them without them screaming bloody murder. It's very painful for them. So just know that with these patients, there's a variety of things. So with diabetic patients, I do not touch their feet without asking them first about how their feet feel. Are they sensitive to touch, or are they non-sensitive to touch? Because I really want to know. I'm going to still look and check no matter what they tell me, because even if they say they can feel, maybe they don't know that they can't feel something. But it's really good to know where they're at, because you definitely don't want to touch them. I've been kicked before because when I've made the mistake of not asking. And then I also want to maintain euglycemia, or a stable blood glucose, as always, to help manage this, because the more stable their blood glucose, the less of these blood vessels that are getting broken down, the less of the nerves that are getting damaged. Pain management is key. We use medications. You'll hear like gabapentin or Neurontin help with nerve pain specifically, and there's a few others as well, but that's the most common one given. Preventing injury and skin assessments and foot care are key. And so we already talked about foot care in another PowerPoint, the other lecture, but just keep in mind, it's all about skin, preventing injury, because I pretty much have to be their eyes because they can't feel it or see it. Because a lot of them, we talked about how some of them, or many people, especially with type 2, they're going to be obese. They're not even going to be able to see their feet. So I have to be their eyes to protect them from injury and do really thorough assessments. So going along with that, they are also high risk for foot ulcers and amputations. Part of it is that loss of sensation. So again, euglycemia, meticulous foot care, everything we just talked about. But there's also another aspect that they can have complications as a result of PAD, or peripheral artery disease. Now, we haven't learned about this yet, but this is a cardiovascular problem, which gets me so excited. So that has to do with the fact that with patients that have diabetes, they're going to be higher at risk for all cardiovascular disease, including vascular disease like PAD, and they're going to be higher risk for building up plaques and cholesterol. And PAD is an occlusion to the feet or the arms, but it's usually the feet. And so where pretty much there's so much cholesterol plaque buildup that there's actually an occlusion where blood cannot flow to the feet. So for these patients, I'm of course going to do euglycemia like everything. This is another one where managing hypertension is key. I need to manage that flow to the feet. And then there's also, they may be on stuff like statins to help decrease their cholesterol, or antiplatelets as well, but you guys don't have to know too in depth into that treatment. But there's also bypass surgery where we do what's called a FemPop, or a femoral popliteal bypass. And that's where we are bypassing that blockage that's in their legs in order to get flow to the feet. So they can also have problems with emptying. And so you can kind of sum these up, like the fancy name for this is diabetic autonomic neuropathy. But the easier way of looking at it is it's problem with emptying. So like it's talking about here, like what happens is there's the nerve that tells the sphincter that helps separate the stomach and the small intestine to open, to empty. And there's also a sphincter that, a nerve that helps to tell the bladder to empty. And both of these can be damaged because of the nerve damage that happens with diabetes. So gastroparesis, and you think the gastro there, and then paresis is kind of like a paralysis. So the stomach is paralyzed. So there's delayed gastric emptying. And so in other words, I'm not like all the food and fluids that are in my stomach, it's not getting emptied. Well, here's the problem. We haven't talked about GI yet, but something to know is that a lot of people probably think that they do a lot of absorption of nutrients in their stomach, but it's actually pretty much all in your intestines, your small intestines. So if I'm not emptying stuff into my small intestines, I'm not going to absorb nutrients. And, that's a problem. There's malnutrition. But the bigger issue here is that all the sugar that I'm trying to absorb, especially let's say that I'm taking insulin and then I'm expecting some sugar to be absorbed because I'm eating that meal after taking my insulin, they can end up having hypoglycemia as a result of this. So I have to watch for signs of hypoglycemia. Remember that cold and clammy, give me candy. I'm going to need to be watching that closely. Other treatments, there's medications that can help to speed up gastric motility or gastric emptying. We'll talk about these more in GI, but there's metoclopramide, also known as Reglan, which helps to increase gastric emptying and speed up motility. There's also erythromycin that does something similar. And erythromycin is an antibiotic, but it does have properties that help with gastric emptying. So then on the opposite end of the spectrum, or I should say opposite organ, and it's not really opposite, but lower organ, whatever, neurogenic bladder, is that your bladder can have the same problems. And the issue here is that you're retaining urine. And if your bladder gets so full, then you can end up having your bladder can explode, your bladder can rupture. It can lead to some very serious complications. But anytime you're having urinary retention too, you're also at higher risk for getting a UTI or urinary tract infection. So again, the bladder's not receiving the signal to release urine. So what are we going to do with these patients? So we do timed voiding, where we regularly take them to the bathroom. The Crates maneuver, which is where effectively you push down on, and I'm going to show them. Okay, I'm making sure you can see in the camera. You push down on your bladder to literally try to help force that sphincter to open. Worst case scenario, remember, we always do least invasive first, then we can do things like self-catheterization as well. There are some medications that you can use to help with the, to help stimulate to open that sphincter, relax the muscle. But you don't need to know too in depth. Just know we do medicines, we change, how they're voiding, try to put some pressure on that bladder to help it to open. But worst case scenario, then we're going to go to self-catheterization or a straight cath. So there's some other problems because of nerve issues. There's what's called cardiovascular neuropathy. And this is where, because the nerves to, different places like the sympathetic nervous system, the heart, things like that are damaged, they can have issues with their cardiovascular system, which is, so sad. They can have postural hypertension or they have to change position slowly because they'll get lightheaded and dizzy with position changes. Resting tachycardia can happen as a result of nerve issues with diabetes. And probably the scariest one is a painless heart attack. So because normally when you have a heart attack, your chest hurts because it's ischemia and your body's telling you, hey, I'm not getting flow. Because of the neuropathy, sometimes patients can't even feel when they're having a heart attack, which is why, you'll learn about in complex about how with heart attacks that people that are diabetic present differently. So we have to look for more subtle, less subtle signs. Is that right? More subtle signs? You understand what I'm trying to say. You'll have to look for less obvious signs that the patient is having a heart attack. So yes, don't mind me. It's end of the semester of the previous semester when I'm doing this. So I swear that I know what I'm talking about, at least 50%. So there's also erectile dysfunction or decreased libido due to nerve damage because there's a lot of nerves down in the perineal and genital area. And so as a result of that, this is really important for patients. And I'll hit this home in a lot of my lectures. This may seem like a minor thing, like I'm much worried about them having a painless heart attack than not getting an erection. But for patients, this is so key. And a lot of them will stop taking medications, stop being compliant if this is going on. It really affects their quality of life. So take this seriously when they bring these complaints to you. It's not an easy topic to talk about. Don't be afraid to ask about it, make sure to refer them to resources. There's counseling that they can go through and also erectile dysfunction meds that can help. So another complication of diabetes can be what's called hypoglycemic unawareness. And this is what happens where people, I talked about when I talked about hypoglycemia that some people can be down at like 30 and be like, I'm fine. And this is not a good thing. Like to not feel your hypoglycemia is not a good thing. It means either your sympathetic nervous system is like, bro, you're always going low. I'm not even going to work anymore. There's also damage that can happen to stop you from stimulating the sympathetic nervous system. But in other words, your body doesn't know when it's low. So you could have walking around with a blood sugar of 20, which is almost coma state. And some people are driving. This is what happens. Some people come in and they have a car accident. And they like, I don't know what happened. I was fine. I didn't get hit by anybody. I just passed out. And this is what happens is they're hypoglycemic. So it can really cause some serious injury and problems for this patient and others if they're out driving on the road for sure. So people that are going to be more at risk for hypoglycemic unawareness are people that have several episodes of hypoglycemia. Because again, we kind of talked about downregulation, but your body, if something's happening all the time, your body does start reacting differently to it. Older patients are going to be more at risk because they tend to show different symptoms anyway. And those taking beta blockers, it doesn't have to be metoprolol, but any beta blocker that's any beta blocker actually. And we'll talk about this when we get into cardiac, but effectively, normally in a patient that is hypoglycemic, we talked about some of the fight or flight stuff that happens. My blood sugar is low, so my body's like, hey, I need more sugar. And so it stimulates the fight or flight or the sympathetic nervous system to go, 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 go. And so the point of the sympathetic nervous system is to help me to compensate for that low blood sugar, but it's also to alert me that my blood sugar is low. Because if my heart is racing, if I'm sweating, if I'm like in panic, like I feel like a bear's chasing me mode, it's going to warn me, oh, I need to get some sugar in. I have a low blood sugar. Well, beta blockers block the sympathetic nervous system. So if I'm on a beta blocker and I'm a diabetic, I'm at risk, I'm not necessarily, and there is some studies that show that beta blockers do also increase your risk for hypoglycemia in general, but don't worry about that. It's more about the fact that they're masking the signs of hypoglycemia. So all those signs, the racing heart, the sweating, the restlessness, irritability, that's like the kind of like, I would say, the anxiety that I feel when my sympathetic nervous system is activated, that's gone because it's being blocked by this medication. Now that's great for hypertension. I do not want my fight or flight activated. It's going to help me with my hypertension, but it's also going to block me from knowing that my blood sugar is low. So patients that are on beta blockers are going to be at a higher risk for this hypoglycemic unawareness, because we're literally blocking the thing that's telling them, hey, your blood sugar is low. And so what we usually do for these patients is that we manage them at a higher than normal level of blood glucose. So in other words, like, most patients, we want to keep them in that nice 70 to 100 range. So the doctor's probably going to want to keep them a little higher because we don't want to mess around. So we'd rather their blood sugar be a little bit higher, not crazy, but a little bit higher than, because hypoglycemia can kill you and, like I said, other people as well. So other complications. Infection. So I talked before that, that diabetics have an impaired immune defense. In other words, their immune system is not as strong as others. They don't have that same like oof or like drive in their immune system, or their white blood cells don't mobilize as well as they might in someone who's not diabetic. So because of this, we definitely need to be always looking out for infections, and infections can happen anywhere. They're going to be higher risk for lung infections, urinary tract infections. If they get like a cut or a scrape, it gets infected a lot more easily. So specifically, some places you might want to look at for women, recurrent yeast infections are common from glucose that's being lost in the urine. There's that increased chance of a UTI, so definitely let them know what the symptoms of a UTI are. And then we can also do treatments and kind of help them to prevent UTIs, staying clean and dry, wipe front to back. And then the general stuff to prevent infection: wash hands, get all your vaccinations. That especially helps with the lung infections like influenza and pneumonia, if they can get those vaccines done. And then, of course, like avoiding sick people and large crowds, especially if they're high risk. On top of that, like they're on steroids, stuff like that. So, and then psychological. So there's high rates of anxiety, depression, and eating disorders in patients with diabetes. So just know that this patient's going to need a lot of psychological support, therapeutic, communication, medications for depression, anxiety. It's possible they may need it, because there's a lot of them, especially type 1 diabetics. A lot of them spend a lot of their life in the hospital in crisis and have a lot of issues. And so just being supportive as a whole for these patients is key. So in general, kind of to sum up how I help prevent complications, doing a thorough head to toe, especially with the skin, looking under everything. I can't tell you how many times that I've come in and, I've taken I always take the SCDs off. I take blood pressure cuffs off. I look under and around everything. And how many times I've found a medication patch that no one knew was there, or an IV that's not even charted on because no one found it because someone's kept a blood pressure cuff on for 4 days in the same place and never looked under it. So it's really important to look under everything, especially if they have skin folds, which a lot of patients with type 2 will have skin folds. And so looking under everything, looking for yeast, looking for infection, irritation, checking that skin. Medication compliance is key with these patients. Like you can see, for the treatment for all of these is managing that blood glucose, keeping it stable. The more stable that blood glucose is, the less chance of complications. You can see a lot of this is about cardiovascular health maintenance, regular cardiovascular health monitoring, checking cholesterol, watching my blood pressure, looking at if there's any blockages in my heart or my other blood vessels, that kind of stuff. General regular health screenings and health maintenance, watching that hemoglobin A1C, getting my eyes checked, checking my urine for albumin or protein in my urine. Those are all key as well. The aseptic technique, preventing infection, is really important for these patients. And then other stuff can help too. Weight loss, dietary changes, especially for that type 2 diabetic, can be super helpful to help manage that blood glucose. Regular exercise, we talked about, helps for cardiovascular health, as well as helps with managing my blood glucose. And then quit smoking, because if my blood vessels are already getting shredded by glucose, smoking is just going to constrict them and make that make it that much worse. All right, so we survived complications. Now let's talk about medications. So like I said, this is going to get overwhelming because I'm going to go through and there's probably like 7 slides of meds. And in class, you know, I usually do more activities to bring it together because it's really hard to process all these. But the best way to approach medications is read this information. You can make some flashcards, especially to remember the names, the times and stuff like that, or the general stuff. But keep in mind, it's not about memorizing rules about these medications as much as you need to practice scenarios. So as many times as, and I'll have other videos with practice questions and maybe some scenarios and stuff on them, but utilize your resources to really start like case studies and things like that to see what could happen with these meds. Because you can study all day long, hey, take this one with food, hey, don't take this one with food, hey, this one causes this. But until you see it in a scenario, it doesn't really make as much sense. So definitely want to practice scenarios. And I have a lot of stuff on my Google Drive, different practice stuff. So feel free to utilize those resources. So getting into what do these patients need? So we talked about before that type 1 diabetics are always going to need insulin because we have to replace what's not there. They don't have insulin, so they're going to always be, so that's why it's sometimes called insulin dependent diabetes. And so they're going to always be on insulin, whereas type 2 diabetics, they could be on insulin, or they also could be on oral medication. They could just be doing diet and lifestyle changes, or they could be doing a combination. So how do we give insulin? We give insulin subcutaneously. And so that's in fat tissue. And most often we give it in the stomach. We can also give it, and I think on the next slide, I have pictures of all the places you can give it. We give it there because like other routes, it will either be destroyed, like the GI tract will not absorb insulin correctly. Intramuscular has too many blood vessels. I talked before, and I'll talk a little bit more about why it's so important to administer this in subcu tissue, because otherwise it can be absorbed wrong. You know, the way that insulin was made is to chill out in your fat cells and be slowly released, especially for like intermediate acting and long acting. So if I'm not injecting in the right place, I'm getting a bolus of insulin super quick. And then like I mentioned there, like the subcutaneous fat allows for slow, sustained release. It's a better blood glucose control over time. And the only type of insulin that can be given intravenously is going to be regular insulin. And that's just because of how it works. Like, you know, long-acting insulin is much more bigger powerhouse. So if I'm giving that IV, it's going to be too much, too fast. And then the rapid is, I'm going to be, it's not as predictable as the regular insulin is. So regular insulin is the only insulin that we ever give through the IV. So you should never, if you ever see an order for Aspart, IV, that's incorrect. So yes, you'd always want to question that. So here's your injection site. So most of the time we're going here in the abdomen, in the back of the arm. I've never given it in the butt or in the back or in, I've maybe once given it in the thighs, but usually we're going for belly or back of the arms. And usually you can ask your patient's preference for that. So to draw up insulin for NPH, you roll it, which in reality, in real life, we don't roll, we don't mix insulins in real life. So don't worry, we're not going to ask you any questions about that. It's mostly just about knowing about the general procedures. So, you know, we get a prep pad, wipe off the top of that vial. We draw up air for how many units we're going to draw up. We're going to inject the air and then flip the vial over and draw up however many units that we have ordered. And then have a second nurse verify that. There's also insulin pins, and these are more often used for intermediate acting or long acting insulins. And these you are going, it's got a little button on this, I got a button, I don't want to say don't touch the button yet, but it's got a little twist on the side and you twist it into how many units you want. So this is really helpful for people that may have poor eyesight, which who might have poor eyesight? I don't want to say a certain type, diabetics that have diabetic retinopathy. So, keeping in mind that this is really helpful for those patients, and effectively then you attach, this is like the actual needle, and you stab the needle into them and then push the button with your thumb and it injects that insulin. Same thing, you're still putting it in subcu tissue. When I'm administering, I'm going to clean the site. I'm going to find a site that I usually try not to poke right where they last were poked, or where there's a lot of bruising or other things, especially if they're getting Lovenox too as well. I'm going to inject it at a 90-degree angle and then safely dispose of my needle afterwards. So there's this safety on the end of the needle. You always want to make sure to get that safety. It's a good tip for clinical, especially if you're my student, that I want to make sure you are correctly putting away that needle, or putting that safety on as soon as you're done administration. Wash hands, you're going to rotate sides. So you're going to hear mixed stuff about this, because some people say you kind of stay like in the same area and you're like, okay, I'm going to stay in this area for a while, but you're not doing it in the exact same place every time. We're going to talk about why here in a little bit, about some complications of using the same site all the time. You don't want to exercise the site after administration. So let's say that I did the arm and I don't want to be doing some Tai Chi or punching or anything like that right afterward. Or if I did it in the leg, I wouldn't want to go for a bicycle ride right after. That increases the absorption of the insulin, and the whole point. And so like we don't rub it in, we don't put pressure on it, we don't do anything, because that's going to increase the absorption of it. And the point is it's slow over time. If they're extremely thin, and I have never had to do this, there's no one that doesn't have at least a little bit of fat tissue, then you can administer it at a 45-degree angle, but this is going to be a very, very rare case. So now we're going to go into insulin types, and there's this table in your book that kind of breaks down. You just need to know the rapid, short, intermediate, and long acting. Don't worry about this inhaled. But we're going to start getting into, and you see a bunch of numbers, you start getting scared. So I'm going to hopefully start to alleviate some of your fears and concerns around these numbers and help make it more simple. Because if you just look at them and memorize the numbers and they don't make sense about what they are, this is a lot of what I talk about. A lot of students struggle, especially on their first exam, is that they don't see the connection between information and how it's going to apply to a situation. So I can remember that, hey, intermediate acting insulin onset is 1.5 to 4 hours. But if I don't know what an onset is, or the peak is 4 to 12 hours. If I don't know what the peak is, if I don't know what that means for the patient, I can't answer a question. So it's really bringing meaning to this information more than anything. So first, do not freak out about all the numbers. Really start to look at them like this. When it says the action, or also known as the onset, it's saying, when do they need to eat? And this only applies for a few of them. Going back here, your rapid and your short acting, these two are the ones that I'm going to worry about the onset, or when the action happens. And that's because both of these are what we call mealtime insulins. I'm going to take them around meal times to cover the meals that I'm eating. So I need to know when they're going to start working, because that's when I need to feed the patient. The other ones last longer. They do have an onset, but I'm not giving them to cover meals, so I'm not as worried about it, but we'll talk about it. Peak, this is the one, if you learn any number, let's say that you had, like, please don't do this, but let's say you just picked one that you want to pick your favorite to study. I would pick the peak, because that's what most questions are about, is about when is the client going to be most at risk for hypoglycemia. So this is saying, the action is, when does it start working? The peak is, when is it working at its best or its most? And so that's going to tell me when the client's going to be most at risk for hypoglycemia. Then with duration, how long is the risk for hypoglycemia going to last? In other words, how long is this medication going to last in my system? Yay, it's good that it's helping to bring my blood sugar down, but the longer that it lasts, it's also the higher chance that I have for having hypoglycemia over time. So the more I need to monitor and watch them. Try to look at the bigger picture, and ask yourself these questions. Does the patient need to eat soon after getting this? Is this for meals, or is this for keeping their blood sugar stable over time? What will the patient be doing when they're at their peak or most at risk for hypoglycemia? So for example, with some of these medications, you have to consider that the peak falls in the middle of the night. What are they going to be doing? Sleeping. And so if they're sleeping in the middle of the night, and if their blood sugar could drop or become hypoglycemic, that's where I need to worry. Like, hey, they're not going to be eating in the middle of the night. So, I need to kind of keep in mind that they probably need a snack before bedtime, stuff like that. And then you want to think, will it last a long time or a short time? So those are some general principles, but let's start getting into some of these names, numbers, and other confusing things. So first type of insulin is what's called rapid acting insulin. I remember these because this is the Humalog and Novolog, also known as Lispro or Aspart. And these log in the quickest time. In other words, they are the fastest. It is rapidly occurring. Action or the onset can happen within 10 to 30 minutes. We usually say about 15 minutes is a good way of thinking about it. The peak starts happening after 30 minutes of getting this medication. It can last for 3 hours, and the duration is up to 5 hours. So it stays in your system for up to 5 hours. So here's a couple, and I have mnemonics for all of these that might help you to study these a little bit more easily. But these are both of our rapid acting insulins. And so like when I said these are mealtime insulins, the point of giving, it used to be that we just gave insulin at meal times. We're like, hey, their blood sugar is going to go up when they eat. We're just going to give that. We would give it to them after they ate. Most strategies to manage blood glucose these days are now centered around trying to keep your blood sugar stable over time. So like I mentioned before, we give them insulin before they eat. And then also sometimes treat their carbs they're about to eat, that carb coverage we talked about in my other lecture, to kind of help manage that as well. And then we also like to give medications sometimes in between that are intermediate or long acting to keep that blood sugar stable over time, because it's not just during meals that people can have a higher blood glucose. So I really as a whole want to keep their blood sugar stable over time. So these are what are called bolus insulins. And so these are given as a bolus at a time when I know their blood sugar is going to be higher, like during a meal. So these are mealtime or bolus insulins that are going to help to keep their blood sugar not from spiking too high associated with a meal or an increase in blood sugar that's sudden. So another mealtime or bolus insulin is going to be short acting, also known as regular insulin. Remember, this is the only type that can be given IV push or through a continuous infusion. So if you have a patient in DKA that's on an insulin drip, this is the type of insulin that they will be on. So this is also known as Humulin. The other one was the logs. This is Humulin. And Novolin, and I always remember it shows up regularly or on the regular. It's not the quickest, it's not rapid, but it's regular or average. It starts working, or this is again, remember action. This is when we need to feed them, is within 30 minutes. So like with this patient, they need to eat within 15 minutes. Usually about I need to start feeding them within 15 minutes of them getting that insulin. Whereas this patient, I'm going to, I can wait up to 30 minutes, but again, we're not trying to wait to the last dang minute. So yes, this is really important because, for example, when you're at the clinical site, you might notice that some nurses, they have this due, but they give it late because they're waiting for their trays to arrive. They're not going to give this until their trays arrive to the floor so that they know they can give this insulin and then make sure that the patient can eat. The peak is 2 to 5 hours, and then it lasts up to 8 hours. And this is something to keep in mind because that peak is later on and it lasts up to 8 hours. There's a longer chance of hypoglycemia, so I do have to keep an eye on this. So those were your two bolus insulins that we give during meal times. We want to know onset is when we're considering onset, we want to think about, okay, when is their tray going to be delivered, and things like that. Peak, that's when we want to think about, okay, what are they going to be doing during that time? Make sure that during that peak that they have eaten something at some point in the last few hours, and that they're, we might have to watch their blood sugar more carefully during that peak time. Now we're going to get into what we call basal insulins. And basal insulins, think basal like a base insulin. It's going to help to give kind of a base good euglycemia blood sugar control. So that way I don't need so much. So you can also think of this kind of relating back to some respiratory meds. The rapid acting and the regular are kind of like my rescue medications. They help come rescue me when my blood sugar is high or going to be high because I'm about to eat a bunch of food, etc. Whereas my basal insulins, which is intermediate and long acting, those are going to help me kind of like long acting medications. They're going to help me over time so I don't need to be rescued so much like with the rapid acting and the regular. Like if I have really good blood glucose control, and some people are managed mostly just on intermediate and long acting, but they still have the others if they need it. So this is going to help me over time so I don't need as much of the others. Now, again, for a while, they started just saying like, hey, why do we even need to do the, rapid and short acting? Let's just do this. But we really don't want those spikes at mealtime. We don't want those highs. So a lot of people are managed with both of these. Some people are only managed with one, but just kind of depends on the patient. So NPH, I remember, nice prolonged hypoglycemic effect. So in other words, it's in, or you can remember it's in the middle, humulin N and novolin N and NPH. So the onset doesn't, it's not that it doesn't matter, but I'm not sitting there and saying, oh, they got their NPH, an hour and a half later, they have to eat, because this is going to have slow release effects. But I am going to be needing to watch their blood sugar at that peak of 4 to 12 hours. So about 4 hours in, I need to keep an eye. So let's say that I gave this at 9 o'clock at night, and I have to consider 9 to 10, 10, 11, 11, 12, 12 to 1. So around 1 o'clock in the morning, they're going to be at high risk for hypoglycemia, and they're probably going to be sleeping. So that's why a lot of patients that get this, because they usually get it either in the morning or at night, I need to make sure in the morning, I'm not as worried because they're getting meals throughout the day, but at night, I always usually make sure patients that are on the long acting or MPH get a nighttime snack to prevent those, the hypoglycemia in the middle of the night. And we'll talk about what that's called and issues with that, et cetera. And this can last up to 18 hours, which is great because it helps to last over time. So this one, basal insulin, just helps to keep my blood sugar stable over time. Don't worry about meals so much, except if it's given, at night, I'm going to be worried about them. I always want to watch that peak and think about like, okay, during that peak, what are they going to be doing? Long-acting insulin. So this one can last up to 24 hours. Super cool. And it has no peak, which is awesome, which means there's like, with NPH, I have to worry about that peak, that drop. I don't have to worry so much about with this one, that there's not really a time because it's really well sustained. But I do always still have to keep an eye on this, especially if this is given in conjunction with others. So it has a large effect, or it gives, like I said here, the other mnemonic is the dose gives extra time. So if my name starts with an L, I last a long time and never peak. So Lantus and Levemir are the brand names, but you're going to need to know the Glargine and Detamir. As the brand generic names. So definitely you can kind of see that they have a large effect, and dose gives extra time is the way that I remember these. But effectively, these have a lot of benefit through them. They help keep your blood sugar stable over time. There's no peak, so I'm not as worried about that hypoglycemia. But again, it's not that I'm just like, hey, there's no peak, so I never have to worry. You still got to watch their blood glucose. So insulin is stored, and hopefully that wasn't too overwhelming. I know that's a lot, but hopefully breaking it down and kind of looking at it in situational will help you do lots of practice questions. So insulin is stored in unopened containers that stay in the refrigerator. We can keep them up there for a month, about 4 weeks. They need to be kept out of sunlight. Oh, sorry, I said that backwards. Unopened containers stay in the fridge and they stay cooled and stuff like that. But once we open them, then they need to be kept out of sunlight, room temperature, and they can be kept for about 4 weeks. So you always need to be labeling them because, like I said, it becomes a really big problem when patients, they don't want to pay for a new vial because they're like, oh, I've only used a little bit of it. So they just keep using it, but it's expired. Because, I know a lot of times you guys have probably used like, oh, it's just a little day old or whatever, it'll be okay. And some stuff, maybe it does okay with it being expired. But insulin's not something you want to mess around with or miss. So definitely want to make sure they keep up to date with that. We talked about continuous glucose monitoring and how you can use that in conjunction with an insulin pump. So let's talk about what an insulin pump is. It gives continuous regular insulin over a 24-hour period. There's literally a pump that is dispensing insulin. And it's like having an insulin drip, but it's actually in your sub-Q tissue instead of in an IV. So you can see it goes into the sub-Q tissue, and I do have to change the site every 2 to 3 days. I don't just leave it in the same place forever. We have to rotate sites. But effectively what I'm doing is giving continuous insulin for tighter blood glucose control. There's an hourly rate that I can adjust, and I can give boluses at meal times and stuff like that. It helps for better blood glucose control, especially someone who's a really brittle diabetic. And it also gives flexibility with meals and activities. So let's say that, instead of I'm sitting there and I'm waiting to, I'm like, oh, I took my, I have to make sure my meal is here before I can give my insulin, et cetera. There's a little bit more flexibility there. And then I also don't have to worry like, hey, if I eat more than what I was expecting or whatever, I can just adjust my pump. So there's a little bit more flexibility with that. I'll give you, for instance, let's say you're on regular sub-Q insulin and you got to a restaurant. Well, then there's a wait at the restaurant. You took your insulin, but you're like, oh God, I'm going to get hypoglycemia before I can get this meal in because the onset was like, let's say it's taken over 30 minutes and you took some regular insulin. So that's why with the insulin pump, I can wait to give that bolus and other stuff, and I can more directly, it can more directly help a little bit quicker. That way I can just be like, okay, well, now I'm about to eat. So here, let me give this to myself. Disadvantages, they do need more frequent monitoring. There's something in you that's not you, so that's always a risk for infection, and of course it costs more. It's definitely usually only used for patients that are just very, very brittle diabetics that need that help. So tissue complications, they can have either what's kind of like this swollen, inflamed appearance to their subcutaneous tissue, or this sunken in appearance known as hypertrophy or atrophy, a thickening or a wasting of your tissue. And it's usually as a result of using the same injection site too frequently, or your subcutaneous tissue starts to have an abnormal reaction, which is why rotating sites is so key. So here's another confusing issue that a lot of students struggle with. So I'm going to do my best to explain this. I do have some, I find it that drawing it out and writing it out, and again, doing scenarios helps. So there's 2 times, and I'm sure there's other times too, but there's 2 common things that can happen to patients where they end up waking up with hyperglycemia in the AM. And anytime someone wakes up with a high blood glucose, you know, we want to figure out what's going on. Is they're not getting enough insulin, or what's happening? So there's the Samoji effect, and this is, you know, you can kind of see like so much insulin. It's actually as a result of too much insulin at night. So what's happening here is that a patient is, like we talked about, remember that NPH scenario I gave you? You take NPH, but then your peak is like starting around like 1 to 3 in the morning. And so 1 to 3 in the morning, these patients, what happens is that they have too much insulin at night. So they get their NPH, they don't eat a snack, or it's too much NPH or something. And it doesn't have to be NPH, it could be any insulin, but just, you know, keep in mind, I'm just giving that as an example. But they get too much insulin at night, they don't have a snack, and they or they have too much insulin and given to them at that time. So what happens is that in the middle of the night, whenever that peaks and they're not eating, they go into a state of hypoglycemia. Well, your body doesn't just take hypoglycemia like and say like, oh, I'm hypoglycemic. It's going to compensate, because your body has a compensation for everything. So the middle of the night, the body compensates, stimulates the fight or flight. Everything is activated. That's where they wake up with like night sweats and headaches and things like that. What happens is that their body compensates, and then they end up with a high blood glucose by the morning. So in other words, and let me explain this again, because I'm sorry if I was a little scattered there, but effectively what I'm saying is they get too much insulin at night, or don't eat a snack after getting their insulin. They wake up in the middle of the night, and they don't have to necessarily wake up, but in the middle of the night, they end up getting hypoglycemic. Their body compensates, and then they wake up with high blood glucose. So most people, if someone wakes up with a high blood glucose, they're going to think, oh, they need more insulin. But here's the problem, is they actually need less insulin, or they need to eat a snack. The only way to actually confirm that this is what's going on is to check the blood glucose around 2 to 4 a.m. and that's when it's going to be low. So that's the only way to confirm that this is the Samoji effect. Because there's also what's known as the dawn phenomenon, which is also a hyperglycemia in the AM, but this is a result of growth hormone. So this happens more often in teenagers that have diabetes and stuff like that, but pretty much growth hormone decreases the amount of glucose uptake that you have. So these patients, they take their insulin at night, whatever it is, and then they don't ever have a drop in their blood glucose, but around 2 to 4 a.m., growth hormone is stimulated, and then their blood glucose gets even higher. So they just wake up with this really, really high blood glucose. And for them on their side, because they have too much, like their blood sugar's never low. They're not having a problem with their blood sugar dropping. They're having a problem where they have a high blood sugar, we treat it at night, but then as the night goes on, because of growth hormone, their blood glucose is going up, 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 up. And as a result of that, then they end up waking up in the morning with a very high blood glucose. For them, they're going to need more insulin at night, or we're going to need to check them in the middle of the night, like halfway through the night to give them some insulin there to compensate for that extra. I think it helps. And so the dawn, it's like you need to give go down, the insulin is down, so we need more. So let's look at this. So this is kind of like, let's say that this is at night. We're going to do the Samoji effect first. So let's say that this is at night. My blood sugar, let's just say it's 200. I take some insulin at night. What happens with the Samoji effect is that I take some insulin, but I don't have a snack, or it's too much, and my blood glucose bottoms out, middle of the night. But then my body's like, oh, no, I'm going to compensate. And in the morning they wake up and they have this really high blood glucose. Whereas with the dawn phenomenon, okay, same thing. My blood sugar is 200 at night. My blood sugar is a regular, like I took insulin, so my blood sugar goes down a little bit, but then halfway through the night, growth hormone comes in and gets secreted, and then my blood sugar is high. So both these people wake up with a high blood glucose, but like we talked about here, we need to see what's going on. So like really for both of these, what we're going to do is check their blood glucose between 2 and 4 a.m. If it's low, it's Samoji effect because they had that hypoglycemia. They need less insulin. If it's high, it's growth hormone issue and they need more insulin or more frequent checks. Hopefully that makes sense. So now that I have confused you with the Samoji versus dawn effect and gone through all the insulins, it's time to get into the oral medications. But luckily, these are the last medications for this section. So there are a lot of diabetes oral and other medications, and we need to figure out, how they work. And so don't spend all your time trying to write down exactly how they help with insulin and things like that, because at the end of the day, it doesn't really matter if they utilize insulin better, absorb glucose better, help cells, blah, blah, blah. It's just about recognizing, okay, if this is how they help, then what do I need to do as the nurse when I'm administering this, or what considerations do I have? So really focus on that role of the nurse when you're looking at these. But here's just some examples of how diabetes oral medications can help. They all help to get the blood sugar more stable. All these medications, just like insulin, will lower your blood glucose. So all of them, I'm going to be concerned about hypoglycemia. So if you're making flashcards and all of them just say hypoglycemia on them, those are not helpful. Always try to write down what is different about a medication, not what's the same. Now, if it causes a profound hypoglycemia, definitely want to include that. But if they're all just like, hey, this is going to lower your blood glucose, well, yeah, that's what it's supposed to do. So all of these are going to do that. But some of them do it by helping to absorb glucose better. Some of them do it because they help your cells to stop being so finicky. And remember that X I talked about where the cells are like, nope, not coming in insulin. I'm not going to use your key. Some of them help so that the cells are more receptive to the keys of insulin. Some of them help to utilize insulin better or stimulate insulin production itself. And some help to manage glucose utilization or storage better in the liver. So there's a variety of things that we can do. Excuse me. All right, let's try this again. So probably one of the most common ones you're going to see, and this can be used, this is the first slide, it can be used before a patient even has diabetes. This is used for a variety of conditions, insulin resistance and things like that, but it can be used to prevent diabetes as well, or help to slow down the progress of diabetes before someone's fully diagnosed. So metformin or glucophage, this is a very helpful medication that it works by reducing your glucose production in the liver. So I always say little glucose will be forming in the liver if you like some mnemonics. One of the major concerns that I have for this patient is they can go in, and it's just because of how the medication works, but they can go into a state of lactic acidosis, which is a type of metabolic acidosis, if you didn't know. I'm going to be on the lookout for this. So I want to tell the patients to report any muscle pain if they've had a decreased level of consciousness. And I know you're thinking, well, how are they going to report that? Well, someone needs to know that that can happen. If they start breathing fast, those are all signs of lactic acidosis. Because remember, metabolic acidosis, we compensate with Kussmaul's. I know it's all clicking together. Isn't it fun when it all comes together? We want to tell the patients to stay hydrated. It's really important for these patients. Usually like alcohol or metformin is not a good idea, but because it can dehydrate you and lead to a higher chance of lactic acidosis, but definitely want them to stay hydrated because it's going to help to flush out some of that extra acid if they are accumulating it. This is not for patients that have kidney, liver, or heart disease. It can have some very serious consequences for those kind of patients. And I know you're thinking, well, isn't that like every diabetic patient? But it just depends. Your doctor will work out your risk, but yes. The other thing, if you ever have had a CT scan or certain MRIs, they may ask you, hey, are you on metformin? And that's because it will increase your risk of lactic acidosis, but the contrast and metformin, like it messes with the kidneys. And so usually with these patients, they need to be off their metformin to 24 to 48 hours before they get the dye. Or sometimes if they're on it and they really need that CT, we'll just have to give preventative and other treatments. But just know metformin and IV contrast do not mix well. And then know that GI side effects are common. So this medication, I talked about it reducing glucose production in the liver, but it also it slows down how you're absorbing carbohydrates. So if I'm taking this and then taking it with a bunch of carbohydrates, when your body doesn't absorb carbohydrates, I don't know if you guys remember years ago, there were like chips that people were like, oh yeah, these are really healthy chips. But what they do is they stopped you from absorbing a lot of the carbs, but then you would just poop everything out. And that's how this works. Like, if I'm not absorbing something, my body's like, okay, I'm not absorbing this, but all I can do is crap it out. So it's really common with metformin for them to have diarrhea, especially if they have high carb meals with their metformin. So you're going to see these patients, like if they're complaining of like, hey, I'm just having really bad GI effects, take it with food because that can help relieve nausea. But if they're having a lot of diarrhea, you might want to look at what their diet is and see if they're eating a lot of high carbohydrate foods, because that may be the source of the problem. The point of taking this medication is not, hey, I can take this medication and eat what I want. Same with insulin. We should be looking at their overall picture as a whole and how they're eating. So there's also what are known as sulfonylureas. Glipizide and glyburide are examples. They help to increase more insulin in the pancreas. Glipizide and glyburide will make more insulin produced inside. I am just so clever, ain't I? So yes, I made these years ago, bottle of wine in a bathtub. And yes, I still am amazed at my specialness. So yes, that's a joke, by the way. If you don't know me, I'm very sarcastic. So the biggest thing we're going to watch out here for is hypoglycemia. And something also to keep in mind here is that on the exam, we could ask you about the class, or we could ask you about a specific medication. So if you're making flashcards, you might want to make flashcards for the classes and then also for the individual medications. There's also Megalitnites, these are all the linides. And these also increase insulin in your pancreas, but it does it more rapidly or more short-lived effects. It has more short-lived effects. In other words, even though it does like with the sulfonylureas that we're going to worry about hypoglycemia, this one we're going to be a little less worried. It is going to still have the same effect. But one thing that you do want to keep in mind with these is I always remember MEG, like the beginning of the Megalitnites, that you must eat great. In other words, you need to take this before meals and do not take it if a meal is skipped. Because of that severe hypoglycemic effect, if I take this and don't eat anything, then I'm very high risk for hypoglycemia. So this is one we talked about on sick days, how you're always still need to take your insulin, but I said like with oral medications, it might just depend. And so this is one of those medications I was talking about where you always want to consider, okay, if I'm taking this medication, what is it going to, like if I take this medication, I'm not eating, then this could have very, very severe side effects. So yes, so if they're on this medication, unable to eat, they should call their doctor. Alpha glucositis inhibitors, also known as acarbose or miglatol, these help to slow the absorption of carbs. So I always think glucose inhibitors. So kind of like we were talking about with metformin, it slows down how you're absorbing carbs. Well, in order to do that, you actually have to be eating carbs. So in other words, this medication only really helps if you're actually, at the moment you're taking it, ingesting carbohydrates. So you need to take it with the first bite of every meal. And I'm not saying that you need to eat more carbohydrates with these, but more what I mean is that you want to make sure you're eating something, because it's going to help to slow your absorption of all of your food, so that the overwhelming burden of glucose that your body has is not as bad. So of course, because this is, you always have to think about these medications. Remember I said about if you know generally how they work, what you need to watch out for. So if this is working in my GI system and affecting my motility, it can have GI side effects, or sorry, if it's affecting my absorption, it can have GI side effects. So that's going to be a lot of the side effects for this one. It also can affect the liver. So I'm going to monitor liver function closely. Yes, there's more. There's a few more to go. DPP4 inhibitors. These are the gliptins. Less glucose and more insulin. Gliptin will get your blood glucose shifting, or you can think of them as dextrose production and proliferation inhibitors, which is just a fancy way for saying they're going to help to where you have absorb less glucose and help you to produce more insulin. So they work kind of on both sides of the spectrum. One side effect of this, or two side effects of this medication, is that you're going to be higher risk for upper respiratory symptoms as well as pancreatitis. So these are the kind of things to kind of remember. remember, instead of sitting there and being like, okay, well, this one works because there's less insulin, less glucose and more insulin, excuse me. But focusing on, okay, well, there's a lot of them that are going to do that, but what do I need to monitor for? Okay, well, they have a higher chance of getting inflammation and infection with this one, the eyes with this one. So then there's Sgl2 inhibitors. These are the flozins. And I actually had a student who came up with this, that the sugar is flozin down the toilet. I had the Sgl2 sugar gets left in the toilet, but I love students. I always love your memory techniques, so feel free to share any with me. But this also helps to block where you're not reabsorbing as much glucose and helps to get rid of more glucose, but it does it through your urinary tract. So that's why I'm saying flozing, sugar is flozing down the toilet. It's going to help you to pee out more glucose. Sounds great, right? Except if you remember that infections love glucose. So if there's a bunch of glucose hanging out in your urine, bacteria is going to be like, hey, baby, come on over. Water's warm. So you're going to be at higher risk for urinary tract infections. And then also you're just literally pouring out some glucose. So there's going to be, of course, the risk of hypoglycemia with this. They're also losing fluid from the excess urine they're peeing. So tell them to change position slowly because they could have some orthostasis. There's also subcutaneous injections. There's what's called GLP-1 receptor agonists, the Types. These are a subcutaneous injection that help with peristalsis. So they slow down your peristalsis or slow down your food's ride. And they help to have an increased feeling of being full and help therefore so that you're not absorbing that glucose so fast. That sounds great, except the one thing to keep in mind is anything that affects your GI system can affect your absorption of other medicines. So if I'm taking this, it's slowing down my glucose absorption. It's also slowing down how I'm absorbing my beta blocker or my other meds. So I should not take this with other medications at the same time. So there should be a period of time in between so that way that I'm not affecting the absorption of some of those key meds. Because it's great if my blood sugar is under control, but if I'm not getting my antihypertensive or other meds because they're not being absorbed right, it is not helpful to me at all. Believe it or not, those are all the meds that you have to know the specific in-depths, but there are other medications that affect diabetes, and these are just a few. We've talked about beta blockers, how they can mask the symptoms of hypoglycemia, so that's something to keep in mind. Thiazide and loop diuretics can cause hyperglycemia because of potassium loss. So it's something to keep in mind if you have a patient on those. And then we already talked about steroids too. So steroids, remember the way that they work, they help decrease inflammation, but as a result, they also increase your blood glucose. And so as a result of that, all patients, diabetic or not, are going to need to be monitored that are on steroids, but keep a particular eye on your patients that are diabetic and on steroids, because that can lead to very serious problems. Anyway, that is it. Believe it or not, I know this was a long one, but hopefully it was helpful and started to get you learning a little bit more about diabetes complications and those medications. Remember, get in there, do some scenarios, do some practice, really start putting it in situations, do some case studies, do some, look at practice questions and really see what are the situations that are coming up, what are the considerations. Try not to get too overwhelmed with memorizing these meds, because that's great, you can have them all memorized, but if you don't understand how they're going to fit into your patient's picture or what you're going to do as the nurse, you will not do as well on this exam. So really focus on thinking about that role of the nurse and what situations could come up with these medications. So anyway, hope this helped and see you next time.